Now, what are the hyperglycemic emergencies? कौन कौन सी होती हैं hyperglycemic emergencies? Diabetic ketoacidosis and खोल दें आने non-ketotic hyperglycemic coma. Oh, that is hypoglycemic emergency. This is hyperglycemic emergency. Now the terminology is changed. It's no longer called non-ketotic state or hyperglycemic. Yeah, honk. We used to call it honk, but now we call it HHS, hyperosmolar hyperglycemic syndrome. So it's called HHS, and the other one is DKA. These are the two diabetic emergencies. Of this, DKA is slightly more serious, but when you see the outcome, the prognosis, we'll see in the last slide, prognosis of the HHS is worse than the prognosis of DKA. Why? DKA generally we see in type 1 diabetes, HHS generally in type 2 diabetes. And remember that patients with DKA can have an overlap. They may have a hyperosmolar state as well. There are two clinically distinct syndrome as described, but we have many patients who may have hyperosmolarity as well. They may have DKA, there may be patients who have pure HHS, and there are certain number of patients who may have DKA plus HHS. They both may be present. So why patients with HHS have a bad prognosis? This is because the patients with HHS usually are older. This is seen mostly in type 2 diabetics. They have many comorbid conditions. They may be hypertensive, they may be carrying ischemic heart disease, there may be other problems with the old age, maybe kidney disease. So they have a bad prognosis as compared to DKA. The patients with DKA tend to have better prognosis. Now, what is dysglycemia? Dysglycemia is your abnormal blood sugar. For that, we need to know what is the normal blood sugar. What is the normal blood sugar? What is the normal blood sugar? So, if it is more than 125 in fasting state, usually fasting is 8 hours overnight fasting, and at random or 2 hours postprandial, it's more than 200. This is abnormal. But what is the lower limit? 100. No. 100 is a little too high for a hypoglycemia. No. Prove it further. Technically, we call it 60 milligrams or less. But if a patient starts having characteristic symptoms of hypoglycemia, patients who are poorly controlled, and if you drop their blood sugar down quickly, they can have hypoglycemic symptoms even at higher levels. The threshold may go up, but book says if it is less than 60, you call it hypoglycemia. So dysglycemia can be hypoglycemia. It can be hyperglycemia, which can be hyperosmolar state or diabetic ketoacidosis. So these are three dysglycemic emergencies. There are other emergencies in diabetes, but these are the three dysglycemic emergencies. And we are going to see hyperglycemic emergencies. Now, why there is hyperglycemia? Because there is insulin deficiency. Is it really only insulin deficiency, or there may be something else which can cause hyperglycemia? Yes, what? Decreased sensitivity, good. Insulin resistance. And if there are more than usual counter-regulatory hormones, that can cause, but that would again come in the relative insulin deficiency. That insulin which is required is not present either because of insulin resistance, or there are more counter-regulatory hormones which are outweighing insulin. For example, if there are glucocorticoid in circulation, iatrogenic, that is given by the physician or patient, in our setup, patient take on their own. Or there are tumors which producing cortisol, glucagon secreting tumors. Similarly, sometimes another tumor called FIO, the tumor of sympathetic nervous system, that can result in increased counter-regulatory hormones. But it is the relative deficiency of insulin, or there is absolute deficiency of insulin. The word absolute deficiency is really not really very correct. Even if you take type 1 diabetics, they may have little bit of insulin production. Ultimately, the insulin production fails, but at some stage they may have some production of insulin. But we generally say that patients have either relative deficiency of insulin, which means they have insulin resistance, or they are more counter-regulatory hormones. The insulin resistance is far more than the presence of counter-regulatory hormones, because those diseases are uncommon. They are not very common. The most common problem is insulin resistance. And there may be absolute deficiency of insulin. The insulin is not being produced. How can we find out the insulin is not being produced? We can check C-peptide level, or we can check directly the insulin levels. So if there is relative insulin deficiency, we see hyperglycemia, and because of hyperglycemia, there is profound osmotic diuresis from the kidney. So the patient starts developing dehydration. There is severe dehydration. There may be mild metabolic acidosis. This acidosis is probably because of the hyperviscosity, which causes sluggish circulation. When there is sluggish circulation, there may be hypoxia. So the metabolic acidosis is not a characteristic feature of relative insulin deficiency. This is seen in this absolute deficiency. There is hyperglycemia, there is osmotic diuresis, and metabolism from glucose is shifted to fat metabolism. So when there is fat metabolism, there is production of ketone bodies. Only small amount of insulin is required to prevent shifting of metabolism from glucose to fats. So that's why if there is this relative deficiency of insulin, we do not see a lot of ketoacidosis. In fact, we don't see ketoacidosis. That's seen in patients who've got very severe deficiency of insulin. The metabolism is shifted from glucose to fatty acid. So there is production of ketone bodies. There is severe dehydration, and there is profound anion gap metabolic acidosis because of the presence of ketone bodies. What is metabolic acidosis? When there is large amount of acid present in the body. When there is acid present, bicarb becomes low. So there is low bicarb, there is low pH, and carbon dioxide is blown off as a compensatory mechanism. So the patients have high anion gap metabolic acidosis, which is secondary to the presence of ketone bodies. Ketone can be excreted through the respiratory system. They can also be excreted through the kidney. So the presence of ketone bodies results in acidosis. Now, what are the clinical features of these two conditions? And we see in the pathophysiology, there is osmotic diuresis. It means patient will have frequency of urination. When the patients urinate frequently, they drink frequently. And type 1 diabetics, they may have attacks of polyphagia as well. So this will be one feature. There are certain features which are common to both conditions. So sometimes it's clinically not easy to differentiate between the two. This is DKA or this is HHS. We'll see how can we clinically differentiate. There is severe dehydration. There may be altered mentation present in both. While altered mentation is more a feature of DKA than HHS. Patients with HHS can also present with altered mentation. But patients with DKA, since they have metabolic acidosis, they tend to have more of mental disturbances. Now, these features are common in both conditions. There is increased thirst, there is urination, there is hunger, there may be weight loss, particularly in type 1 diabetics. Those with absolute insulin deficiency, there may be blurring of vision, headache, weakness, postural hypertension. How is postural hypertension manifested? When the patient stands up from lying position, patient has decrease in cardiac output, circulation through the central nervous system decreases, and the patient may have blackout. They may have syncope, and there may be altered mentation just from confusion to even to deep coma. As I mentioned, this is more in DKA, but can also be present in HHS. So on the basis of these, simply we cannot differentiate what is the underlying problem. Now, there are certain features which can differentiate these two conditions. Dehydration is present in both, but in HHS, usually the dehydration is very profound. This is the main thing which differentiates the two. Patients have metabolic acidosis. Metabolic acidosis stimulates respiration. So they have deep, rapid breathing. This is called Kussmaul's breathing. And there may be features of acute abdomen, which are usually not present in HHS. Acute abdomen means patient may have nausea, vomiting, there may be abdominal pain. So the patient may look like this is a surgical abdomen. So that differentiates these two conditions. And if you can pick up, you can find out that this is DKA and this is not. Because in HHS, patient does not have metabolic acidosis. Patients in HHS, they may have acute tubular necrosis because of dehydration. And if this condition goes on for a very long time, maybe more than 24 hours, they may develop metabolic acidosis because of renal failure. But per se don't have metabolic acidosis. Now, what are the labs we are looking for? What labs would you like to do? Oh, no. First thing is do the blood sugar. Prove that this is hyperglycemia. You need serial blood sugars. You don't need one blood sugar only. One blood sugar is to make a diagnosis. What is DK? Diabetes, ketoacidosis. Blood sugar should be high. Ketones should be present. There should be metabolic acidosis. So you need serial blood sugars when you start treating the patient. Maybe you're doing it half hourly or hourly. Generally, we do hourly blood sugars to see what's the trend, is falling at what rate, is it satisfactory or not, and if it has gone to a certain limit, then we have to replace the fluid. So we'll see further. So we need serial blood sugars testing. We do hourly and see what is going on. And remember one thing, in patients who got diabetic ketoacidosis, the blood sugar may not be very high. For diabetic ketoacidosis, usually the blood sugar is more than 250 milligrams. But there are conditions in which the blood sugar may be less than 250 milligram and the patients still have diabetic ketoacidosis. What's that condition? Maybe patient is partially treated, somebody gave injection of insulin, blood sugar came down when the patient reached you. So the blood sugar may not be more than 250. And there is a drug family called SGLT2 inhibitors. Have you heard the name? If the patient is taking those drugs, patient may have euglycemic DKA. So usually it is hyperglycemic DKA, but the patients may have euglycemic DKA. Well, when we see the HHS, the blood sugars are very high. They may be 500, they may be 600. So the blood sugars in HHS are usually very high, but in DKA, the patient may have even lower blood sugar than we expect. So we go for blood sugar monitoring. And then we go for serial electrolytes and osmolarity. We don't generally check osmolarity here, but it's recommended that you check osmolarity. But we check electrolytes for sure because it's very important. Why it is important? Because when you start treating, there may be a start of electrolyte disturbances. For example, a lot of potassium is lost. When there is osmotic diuresis, sodium is retained. And in exchange, potassium is excreted. So there may be total deficiency of potassium. Total body potassium may be low. When you start replacing fluids, the first fluid is saline. When you give saline, volume expands, there may be hypokalemia. You give insulin, insulin causes shifting of potassium into the cell, may cause hypokalemia. So the potassium may go down. That is very serious complication. This is one of the complications of treatment. So you have to monitor the potassium very seriously. In fact, we have to monitor sodium as well. But potassium is more important. Sometimes we require the monitoring of phosphate as well. But generally, routinely, we do not monitor phosphate. But sodium, potassium, mandatory monitoring. Serial blood gases and blood and urine ketones if they are present. If they are present, this is DKA, and we do the blood gas examination. Ideally, we should do the arterial blood gases, but if we have to do frequently, we sometimes can go for venous blood gases as well. So we do ABGs or VBGs. What will arterial blood gases show? As I mentioned, there may be lower pH, there may be low partial pressure of carbon dioxide, the bicarb may be low. So all three may be low in metabolic acidosis. And we check, we may find ketone bodies present in the blood or in the urine. We have got meters which can detect blood ketones. We can measure urine ketones as well. So we can go for a serial monitoring. The blood sugar is monitored hourly. The electrolytes may be depending upon, maybe they be monitored every 2 hours or every 4 hours, depending upon what's the situation. The blood gases and ketones we usually do not measure for, say, a period of 6 hours or even more. So they are monitored less frequently as compared to the blood sugar. So we see blood sugar, electrolytes, and blood gases. This is the way the frequency determined. We frequently monitor blood sugar, less frequently electrolytes, even less frequently the blood gases. Then we go for initial renal function. How are the renal function? If the patient has gone into shutdown, if the patient has gone into the kidney shutdown, then you have to be careful about giving fluids because kidneys will not be excreting any more extra fluid loads. So the patient may go into volume overload, particularly patient who got HHS. They're older patient, they may be carrying ischemic heart disease with them. And if you give them a lot of uncontrolled fluid, that may cause pulmonary edema. Now evaluate for precipitating cause. What precipitated the hyperglycemic emergency? Most common reason is the patients, they omit insulin, especially type 1. Even if a single dose is omitted, it may result in DKA. And you remember, DKA is a condition which can come or develop within hours. A dose is missed in the morning, by the evening the patient is in DKA. While HHS develops over time, maybe over days, 1, 2, 3, 4 days. So DKA can develop very, very quickly, while HHS develops slightly slowly. So the most important reason is missing the dose of insulin, but you can go for certain tests which can tell us that there may be another reason for this hyperglycemic state, like complete blood count, which may tell you about the presence of infection. Infection is one very common reason for precipitating hyperglycemic emergencies. Now, what we see in CBC is there is neutrophilic leukocytosis. But DKA itself can cause some leukocytosis. Then how would you differentiate that this is not infection or this is infection? Have you gone through the hematology? What is left shift? Yes, younger WBCs. If they are present, it means this is a rapid production of WBCs, which is seen in infections generally. But when we have, because of the DKA, when there is DKA, there is stimulation of the nervous system, autonomic nervous system, there may be catecholamines. These catecholamines cause mobilization of marginalized pool of WBCs into circulation, the TLC goes up. So if there is leftward shift, this indicates this is infection. If the patient has fever, and remember, these patients may not have fever. Even some of the patients may be hypothermic. So when we cannot really rely on temperature for the presence of infection. That's why for some time in these patients, we go for empiric antibiotic treatment until we are sure there is no infection. You can go urine examination. You can go appropriate blood cultures, look at chest x-ray for the presence of pneumonia and EKG. One very common reason in adults for precipitation of these emergencies is acute coronary syndrome. These patients may not have symptoms of acute coronary syndrome. They may present with this hyperglycemic emergency, so an ECG must always be done, particularly patients who've got type 2 diabetes and they have hyperglycemic states, either DKA or HHS. So you should do an EKG, rule out a cardiac emergency. Similarly, a cerebral emergency can precipitate DKA. If the patient has developed stroke, there is so profound stress that it can result in hyperglycemic states. Now, what are the differentials of the patient who present to you with DKA? The top differential is hypoglycemia. Is the patient hypoglycemic or not? So sometimes what we do is the patient is brought to you as an unconscious patient. And the attendants tell that he's diabetic. You can give straight away glucose, even without checking blood sugar. Ideally, you should check the blood sugar and document that this is hypoglycemia. But sometimes you can give glucose and see what's the response. If the patient becomes conscious, it was hypoglycemia. Giving a few mLs of glucose is not going to affect, very much. But the ideal condition is that you should check the blood sugar. CNS infections, strokes, organ failures like kidney failure, like liver failure, like type 2 respiratory failure, they can cause, and then certain drugs. So these are the main differentials which should be considered when you're seeing patient with DK who present with altered mutations. So you should look into these drugs. Now, what's the management? What are the management principles of hyperglycemic emergencies? What is the first thing you're going to choose? There is insulin deficiency. So are you going to choose insulin as the first drug? Or someone bookman chup karke baithe ho? No. It's the fluids. First thing you're going to give is fluids. They're going to expand the circulation. Blood sugar is going to come down a little bit on its own, isn't it? Standard of care for comatose patient. What is comatose patients? Prevent the patient from having any injuries, because these patients sometimes can also have fits. Prevent aspiration, that's the most important. If they develop aspiration under your care, it's criminal. You've been a poor manager. Patient should not develop aspiration, because aspiration pneumonia has a very high mortality, particularly in diabetics. And older patients, aspiration pneumonia can mean 50% mortality. So you have to be very careful. The patient should not aspirate. So provide a standard care of a comatose patient. For example, skin care, aspiration, blood and bowel care, and if required, nutrition. Right now, when the patient presents in the emergency, we're not really very concerned about nutrition. So we don't start feeding these patients. Fluid and electrolyte management, that's the most important. You just give fluid. Which fluid are you going to choose? The first fluid is always normal saline. Remember, if there is any reason you want to expand the volume, the first fluid is normal saline. Don't say I'm going to give Ringer's lactate or Hartmann solution or anything else. The first solution is always normal saline. In the first infusion, you do not need to give potassium. It's bland sodium chloride. And how frequently you would give it? It's your assignment. Tell me, you send me the management protocol of TKA and HHS. Kitna fluid, kitni der mein dena hai? That I intentionally kept out of this lecture. You're going to tell me, 1 घंटे में कितना देना है, 2 घंटे में कितना देना है, 24 घंटे में कितना देना है, 48 घंटे में कितना देना है. So we are going to go for fluid and electrolyte management. Second infusion will be requiring potassium, because by that time you have given insulin. You have given saline causing volume expansion. Potassium will come down a little. You started insulin, it will come down further. If you've given bicarbonate for combating acidosis, it will further come down. So all three can cause hypokalemia. Replace insulin. Which insulin are you going to choose? Long-acting, short-acting, intermediate-acting? Always choose short-acting insulin. Which short-acting insulin? Insulin or insulin analog? What are insulin analogs? These are synthetic insulin in which there is some change in the molecular structure of insulin, altering their pharmacodynamics and pharmacokinetics. So we don't use any other insulin except short-acting insulin in acute emergency situations. Kyun Fawad? ऐसे ही है ना, analogs are not recommended. So we use plain insulin. Antibiotics and anticoagulants. As I mentioned, in some patients, if you don't find a reason, consider occult infection as a possible cause of DK or HHS being precipitated. So you can give empirical antibiotics if you have sent the blood and urine cultures. So you can start with antibiotics, you do not delay it. The culture may take 72 hours, even more than that. So we cannot wait that long. So if we send these cultures, we can go for empirical broad spectrum antibiotics. Since these patients are dehydrated, they tend to have sluggish circulation because of hyperviscosity. They may coagulate somewhere in the deep veins or in nervous system or anywhere. So we have to prevent them. These patients should be put on anticoagulation. What anticoagulants would you choose? Yes? Heparin. Why not warfarin? Number one, it takes time. Number two, we do not want to give patients orally because patients with DKA are prone to develop vomiting. They have diabetic gastroparesis, so they may vomit. So we don't want oral treatment for these patients. So we want intravenous, and the heparin works far more quickly than warfarin or even 10A inhibitors. You know 10A inhibitors? So heparin is a choice. We can use the low molecular weight heparins, easy to administer. Correction of acidosis if required. It means you do not routinely correct the acidosis in diabetic ketoacidosis. It's the volume replacement and insulin itself corrects the acidosis. When would you require the acidosis to be corrected? And why the acidosis should be corrected? Number one, if the pH is less than 7.1, consider correcting metabolic acidosis. Metabolic acidosis causes cardiodepression, decreases the myocardial contraction. It can cause vasodilatation. The patient can develop hypotension, which may be resistant. So if there is very severe acidosis, you need to correct it. Otherwise, you don't need to correct it. You just give saline, it corrects the acidosis itself. Treat the precipitating cause. So consider, as we have already seen, antibiotics. If the patient has not taken the insulin, that you have started insulin. And if the patient has acute coronary syndrome, treat according to the protocol of ACS. So this is the management. Now, what are the complications of hyperglycemia? We have already discussed these complications. There may be ATN because there is shrinking in the volume. There is osmotic diuresis. Patients may be vomiting, they're not eating. So they may be febrile, so they develop loss in circulating volume. That can result in pre-renal injury. As patients may develop acute tubular necrosis. So patient may have ATN. Patient may have thrombosis because of hyperviscosity. So these are two immediate serious complications the patients can have simply because of hyperglycemia. And then the complication may be because of the precipitating cause. For example, if the patient has pneumonia or meningitis or myocardial infarction. So they are not the complication of hyperglycemia itself. They are the complications of the precipitating cause. And then we have got this thing. This is far more important. Complications of treatment. You start treatment and you start harming the patient. So you have to be careful. This is one thing, as I mentioned, DK has a very excellent prognosis. The mortality is only 0.2 to something to 2.5%. It's not a high mortality state. So if a DK patient dies, this is really very, very bad management. So now the first complication which you see is hypoglycemia. If you give too much insulin and if you don't monitor, that's what we require the monitoring of blood sugar for, that the patient does not develop hypoglycemia. When you start treatment, the blood sugar starts going down. We give insulin infusion. We don't give stat insulins. We give insulin infusions. Most appropriate way of giving insulin is insulin infusions. And if the blood sugar has fallen to 10 or 11 millimoles or say 200 milligrams, you replace the fluid with dextrose. You stop the sodium, start dextrose, so that patient does not develop hypoglycemia. So the one serious complication of treatment of hyperglycemic emergencies is hypoglycemia. The second is hypokalemia. As I mentioned, there are multiple reasons for hypokalemia to develop. Volume expansion, insulin, giving bicarbonate. They can all cause hypokalemia. hypokalemia can result in muscle paralysis and it can result in cardiac dysrhythmias. So we have to guard against hypokalemia, and appropriate potassium replacement should be started. As I mentioned, with the second infusion, potassium replacement should be started. And then fluid overload, including brain edema. Well, now, what is this brain edema? This is the most serious complication if you have. If you see all these, of this, brain edema may be the most serious. And when does brain edema develop? You see, when you start giving insulin, the blood sugar starts dropping. When the blood sugar starts dropping, it means the plasma osmolarity will start decreasing. CSF blood sugar does not change that quickly. So there will be more glucose in the CSF, less glucose in the circulation. So the fluid will move from less glucose side to higher glucose side because that fluid is thicker, more dense, more osmolar. So the fluid will shift from circulation into the CSF, causing swelling of the brain. That is very serious complication. That's why we want to very strictly monitor the blood sugar. And we do not want a rapid shift in blood sugar so that we can protect the brain. If there are rapid swings in the blood sugar, that can be detrimental to the brain. So DKA and hyperosmolar state, they require very precise monitoring of blood sugar and appropriate management of the fluid. So you just cannot sit and relax and just ask the sister, start this infusion and I'm going to watch something on the YouTube. It's not possible. So you have to monitor the patient. If the blood sugar drops precipitously, there may be hypoglycemia, and then the second problem may be the fluid may shift from the circulation into the CSF, causing swelling of the brain. So these are the complications of treatment. Now the prognosis. The overall mortality, DK is 0.22%, HHS 11%. We have already discussed why there is high mortality in HHS. Patients are older. They are type 2 diabetics. They may have comorbids like heart disease, or they may have kidney disease, and their immune system may be not as good as the younger patients who have DKA. Patients with DKA, why they die? If they're insulin deficiency, we replace insulin, we do it correctly. Even then you see 2% can die. Why they die? The mortality may be because of the precipitating cause. If there is overwhelming sepsis, which goes uncontrolled, patient has a stroke, patient may have a profound large MI, maybe left coronary arteries engaged, whole of it is engaged. So the mortality may be because of the precipitating event or because of poor medical management. Patients who have bad prognosis, they are generally who present with deep coma. Patients who are hypothermic. Hypothermia means a profound sepsis. Those who present with oliguria means kidney injury, patients who are older. So they have bad prognosis. So this is about hyperglycemic emergencies. Now if you have anything else to discuss. जी इंसुलिन रेजिस्टेंस की वजह से हो we just monitor the blood sugar. Is it dropping according to our requirement or not? We require the blood sugar to drop by approximately 2 millimoles per hour. If it is not responding, you can increase the dose of insulin. Insulin sensitizer may not be useful. Insulin sensitizers are metformin, pioglitazone. They may not be very useful in the acute states, so we tend to increase the dose of insulin gradually. Otherwise, the insulin sensitizers may not be useful. So we gradually increase the dose of insulin. If we don't achieve our target, that is the blood sugar should drop by approximately 2 to 2.5 millimoles per hour.
Sir, मतलब मैं ये कहना चाह रही हूँ कि इंसुलिन रेजिस्टेंस में अगर ब्लड ग्लूकोज हाई होती है, डायबिटिक केटोसिडोसिस में भी चला जाता है बंदा, तो वो इस वजह से कि उनके सेल्स अपटेक नहीं कर रहे हैं इंसुलिन की.
Yes.
तो अगर हम इंसुलिन लगा भी देंगे तो उसका फायदा तो नहीं होगा.
So what is competitive antagonism at receptor level? If the ligand is one ligand is more than the other, it will take over. So anything which is causing insulin resistance, if insulin is more than that, insulin will displace it and start working. So that's why we then increase the dose of insulin. Otherwise, in patients who've got decay in type 1 diabetics, they don't have insulin resistance, so they do not generally require escalation of doses, but in type 2, they may require. Anything else? So see you in final year.